We often hear it used as a shorthand for being organized. "I'm so OCD about my desk," or "I'm OCD about my schedule." Clinically, the disorder is an involuntary cycle. It is defined by intrusive thoughts and the physical or mental acts a person performs to neutralize the anxiety those thoughts create. To meet the diagnostic threshold, this cycle must consume at least 1 hour of a person's day and cause a significant decline in their ability to function. This time-based requirement separates a simple preference for order from a clinical condition that dictates a person's daily life. While 1.2% of U.S. adults live with OCD, the average patient waits 11 years to receive a correct diagnosis. This delay is often driven by a paradox within the condition. Most people with OCD recognize that their intrusive thoughts are irrational. Logic, however, is not the driver. The neurological power of the anxiety overrides the rational brain, forcing the patient to act on their fears. Many patients suffer for a decade or more in silence because they feel deep shame regarding the irrational nature of their symptoms. The cycle begins with an obsession. This is an unwanted thought, image, or urge that enters the mind involuntarily. These themes can be dark. They often involve a fear of harming others or intrusive thoughts regarding taboo sexual or religious concepts. Other forms include a fear of contamination or the physical sensation that an object is not in the right place. The brain responds to these thoughts with an immediate, involuntary spike in psychological distress. The brain treats these intrusive images as life-threatening emergencies. It assigns a high-priority alarm to a thought a healthy brain simply dismisses as noise. To stop that alarm, the person performs a compulsion. This is a repetitive behavior or a mental act intended to neutralize the threat. Completing the compulsion provides a brief window of relief. The anxiety drops, and the person feels safe again for a moment. This creates the trap. The brain learns that the compulsion is the only way to survive the distress, ensuring the loop restarts with even more intensity the next time the thought occurs. This mechanical loop is why general talk therapy often fails. Traditional counseling does not always address the physical reinforcement of this cycle. If a patient uses therapy to find temporary reassurance, that reassurance can become another hidden compulsion that keeps the cycle spinning. The clinical standard for breaking this loop is exposure and response prevention, or ERP. During exposure, a therapist intentionally triggers the patient's specific obsession in a controlled environment. Then comes response prevention. The patient is blocked from performing their compulsion, forcing them to sit with the anxiety until it dissipates naturally. This protocol is often supported by medication. Doctors may use SSRIs at dosages significantly higher than those typically prescribed for depression. By surviving the peak anxiety without the compulsion, the brain learns the threat is not real. This rewiring is what eventually snaps the loop. ERP is effective, but it requires specialized, culturally competent care to guide a person through the process safely. Coping and healing counseling operates as a specialized resource to bridge the gap between symptoms and a correct diagnosis. Their team of over 15 licensed therapists provides HIPAA-compliant telehealth for teens and adults across every county in Georgia. To make this care accessible, they accept a wide range of insurance, including Medicaid, which covers these sessions with a $0 copay. Ultimately, OCD is a mechanical cycle. Through expert clinical intervention,